Seven Fareed, and I'll be going to providing your introduction to this event today, along with a team in the background in terms of Christina Titterman and Rebecca Farley. Thank you all. I see that there's a lot of people coming in, logging in from around the world today. We have over 100 registrations. It's great to see, and obviously from different kind of specialties as well. I can see nursing, obs and gynae, surgery. I see a few human factors and they're specialists as well. So we can see a lot of kind of different kind of audiences, which is really good to see. In terms of the RCSI and in terms of what we do, there's a wide range in terms of human factors training that we've done in terms of training for our trainees. And we have a national conference and kind of other pieces, but we do kind of train experts across the world in terms of human factors and ergonomics. So hopefully today, because I know that there's a lot of people registering from different ends in terms of their interest in human factors. Some people are already working in roles that include human factors. Some people are just learning about the topic. Some people don't even call it human factors. They call it communications, teamwork. They call it ergonomics. Today is really about debunking the kind of what you kind of hear and see online, and kind of hearing from our industry kind of experts in terms of human factors and how they got into human factors, and then also in terms of the impact that they're having across different specialties across the world. I asked, and you can see the messages in the group. You can see that in terms of to allow for the smooth running of this event, we just ask you to kind of turn off your mics and cameras, just so the speakers can kind of proceed in terms of what they're presenting. At the end of each of the sessions that we have from the speakers, we will have a live panel, so we do encourage audiences to submit their questions within the chat. And we do have a great panel here today, in terms of including Dr. Marie Ward, Dr. Mohammed Salem, Dr. Emily O'Dowd, Ivan McCann, and Dr. Liam Chadwick, who will give their perspective in terms of their entry point to human factors and patient safety, what they're doing now, and maybe also advice in terms of how you can kind of start your journey within this kind of field in terms of human factors and ergonomics. So, in terms to kick the event off, we'll start the event in terms of allowing Dr. Marie Ward to speak. Dr. Marie Ward is a chartered ergonomics and human factors specialist. She's also health systems and human factors ergonomics learning and research, where she works in the St. James's Hospital. But also, Dr. Marie Ward is the chairperson for the Irish Human Factors and Ergonomics Society, and again, which is well known across Ireland by many kind of doctors and kind of different specialties in Ireland, actually outside Ireland as well. So Dr. Marie Ward, I'll hand it over to you, and again, this will be kind of very good to kind of learn about kind of the different kind of speakers, kind of entry points into human factors. So maybe giving an account in terms of how you got in, the work that you're doing, and then any tips that you'd give to anyone looking to get into human factors.
Great. Thank you, Tevin, so much. And it's lovely to be here with you all this evening. So thank you for the invitation to come. As Tevin said, my name is Marie Ward, and my background is in psychology, and how I got into human factors was a bit accidental. So I'll tell that story first. I was actually finishing my degree in psychology in Trinity College, and I wanted to do organizational psychology, and the professor of organizational psychology who I wrote to ask to do an internship. At the time, he was asked out to the airport, the local airport, because there was incidents with baggage handlers driving into aircraft and damaging aircraft that the airline wanted help with. So that was my introduction. My first start with human factors was actually on that study, trying to understand what was happening. And it was a very simple explanation. It turned out that at certain times of the day, the aircraft wing was in line with the horizon and people couldn't see it when they were driving. So it was very simple. But it started for me a love, I suppose, of human factors, and started my career in human factors. So after that, I went on to do a Ph.D, to do a doctorate in human factors in aircraft maintenance, engineering, safety. So I did that through Trinity College as well, and again loved it. Just loved I suppose having the time to understand systems and to understand complexity and to help prevent aircraft accidents by understanding that complexity and putting in good system design. And I suppose that just, maybe just I'll say, because Tevin talked about different understandings of human factors, I always refer back to the International Ergonomics Association definition of human factors. And to explain, the term human factors arose in America, but simultaneously the term ergonomics was being used in Europe. So sometimes they're called, the science, and it is a science, is called human factors or ergonomics, or sometimes it's called both. So the International Ergonomics Association, which is the governing body for all of our national associations, including the Irish Human Factors and Ergonomics Society, have recommended that we use the two terms, so human factors, ergonomics, to describe the full breadth of the science. And I suppose what is human factors? It is, as I said, a science, and we try and apply systems thinking and systems approaches and human-centered design to understand organizations, but also to support them in change and improvement. And there are two things that are equally important in our efforts, and one is human well-being. So that is whether it is a healthcare professional, a healthcare worker, or a patient or their family. So it is all of our well-being and system performance. So you're trying to improve both and never one at the loss of the other. Okay, you're always trying to work on both.
Push over that way. I love you. Over that way.
We're just somebody needs to just go on mute. Yeah, thank you. So the focus in healthcare of human factors is on quality, safety, and risk, and trying to manage quality and safety and risk in healthcare. And the statistics, unfortunately, around patient harm and healthcare, the harm to healthcare professionals in terms of burnout, stress, fatigue, absenteeism, the level of harm is not decreasing despite 20 years of different efforts around patient safety. So the World Health Organization in its global healthcare plan has said, healthcare needs to really embrace human factors, and that's the full range of the science of human factors. So that's in the WHO Global Patient Safety Plan. And I suppose for me personally, I work in a large public hospital. There are 1,000 patients, and over 5,000 staff members. So it's the size of a small trust in the UK. And for me, what it means to work as a human factors or ergonomics kind of practitioner within that setting is really to work with people. I mean, that's the most important thing, is to work with the clinical staff, to work with the operations and management staff, to really learn and understand how healthcare works as a system, and to try and bring my skills to the table, I suppose, in terms of improving healthcare safety and quality. And I think that is a key to moving the dial on patient safety, is really to have a transdisciplinary approach where we really are humble in our efforts to understand each other, to understand what we do, and to try and bring different expertise in terms of improving safety. So I suppose different projects I have worked on have been improving handover practices throughout the hospital, improving how we carry out ward rounds, how we have consent conversations, shared decision making, using human factors ergonomics approaches to understand the complexity in those tasks and activities, and also to improve them. So using human factors to prospectively improve as well to guide change. And there are simple, kind of socio-technical models to do that, understanding culture, understanding the actions that people take, the behavior, how the system works, and trying to bring all that together. So you have used human factors to guide change projects as well. Anything from removing the spurious antibiotic allergy labels to improving perioperative journeys for patients. So a lot's big range of activities. So happy to chat a bit more in the chat later about that. But as I said, lovely to be here with you this evening, and thank you, Tevin.
Thank you so much, Dr. Marie Ward. I think you can see that there's so many use cases in terms of the implementation of human factors. I think it's fantastic to see, and definitely it's applicable as well in terms of aviation, kind of other kind of the sectors industries as well. So fantastic. So we'll now go on to our second speaker, who is going to be Dr. Mohammed Salem, who's a consultant cardiothoracic anaesthesia and critical care working in John Radcliffe Hospital, Oxford University Hospitals, NH Foundation Trust, Oxford, UK. So Dr. Mohammed Salem, the floor is yours. Again, I'll ask you to maybe explain in terms of how you got into the field of human factors, ergonomics, and the work that you're doing, and then maybe advice for anybody looking to kind of get involved in human factors projects within their own specialty in hospitals.
Thanks, Evan. Marie, how do I follow on from that? That's a great intro. I mean, my name is Mohammed Salem. I'm a consultant in cardiothoracic anesthetics and critical care. And as Tevin has highlighted, I've got about 20 years or over in anesthetics. And my journey into human factors has been slow, but it's sort of got an accelerated rate and rhythm around 2020, when I was the clinical lead for the cardiothoracic critical care and anesthetics unit in John Radcliffe Hospital when we had the COVID-19 pandemic. And obviously I was doing an MBA at the moment at that time. And so I had no problems with management. However, I think one would say is management is totally different than looking at risk and looking at what we would call, or I'd understand now, as the ergonomics of switching everything around in a one-way flow system so that patients can come through one door, leave out the other door. How do we maintain safety for everyone? How do we look after everyone? And how do we make everyone work better together? I'm not going to increase anyone's skills. I'm actually going to, this is what I want. I want them to work in a new, different way together. And from then, sort of started looking into human factors, but I had to finish my MBA first. And once my MBA was finished, I knew that that's the next path that I had to do. I had to learn more about human factors, ergonomics, communication skills. So from there, the RCSI has been a great journey for me because it helped me understand all these things. And one of the things that I have special interest in is communication skills, handover in high stakes environments, especially with the globalization of healthcare at the moment. So I would be more than happy to speak to someone halfway around the world who's not a native English speaker, and I would be able to communicate with them, adequately hand over a patient to them so that they would understand what this patient's needs are and take that patient's care forwards, onwards. And obviously, with the influx of patients that are recruited into my hospital from around the world, my understanding of human factors can help me introduce various aspects of communication, break the hierarchy, allow them to raise awarenesses to the medical team about certain things, or allow them to stop the medical team from making errors if that is necessary. Ultimately, later on, I got involved with a group of medics looking at reducing maternal mortality in the Middle East. And my task was to give a talk about management of major hemorrhage, which happens around the heart surgery. But as soon as I went out there and I gave that talk and the questions I was asked, I knew that people didn't need to know how to manage hemorrhage. What they needed is how to communicate clearer, better, because communication is not only a one-directional thing, it's a multi-directional thing, and it just doesn't happen between two people, it actually happens between a wider group of people, and it could be outside the theatre environment. And I would like to say that that can actually just elevate any team. You don't have to have the world's most cutting edge robotic treatment to deliver the best care. What you need is to learn the basics of human factors, ergonomics, communication, and you will improve your outcomes miles and miles and miles by anyone who has the world cutting edge technology and have paid for it. So I would say this is the cheapest, simplest, and best way to improve patients' outcome. And not only for the theatre team, but also for doctor-patient or nurse-patient communication. I mean, today I had a patient who I had to understand their aspects of worries about what they wanted from an anesthetic, and I had to communicate better. That's due to my human factors and communication skills. And I think lastly, because I want to keep this brief, I want to end by saying at the moment, in this day and age, we have all the information we need at our fingertips. There could be a disease that I don't know anything about, and I could just search it on my phone. However, as an examiner for the European Society of Anaesthesia and Intensive Care, one of the questions that we had on the last examination was about a power outage in theatre and how these anaesthetists would manage these patients. And obviously, this is a question about how would you communicate with the surgeon? How would you manage the patient? How would you mitigate the risk? How would you understand what's happening around you? And I think as things get simpler and simpler and simpler from a knowledge perspective, I think we have to dig deeper and deeper and deeper into our understanding of the communication skills and what people need to do to improve patients' outcomes simply by looking at doing the simple things right. And with this, I would like to thank you all.
Thank you so much, Dr. Mohammed. I think, yeah, that's fantastic. I love the quote in terms of, communication is not one directional, it's multi-directional. I think that's very, very powerful, and how we can improve patient outcomes through the basics of human factors and ergonomics. So, yeah, no, really, really, really kind of hits home in terms of difference. But like, if human factors is used well, I think definitely, it will improve patient outcomes. So thank you so much. We'll now go on to our third speaker, who is, in terms of RCSI, our very own Dr. Emily O'Dowd. Dr. I know Emily very well. Emily is the lead program lead for our Human Factors and Patient Safety program, and has extensive experience in terms of the human factors, in terms of healthcare psychology. So the floor is yours, Emily, in terms of, just letting the guys know in terms of how you got into this field, and the stuff that you're doing, especially in RCSI, the huge impact you're having.
Great. Thank you so much, Tevin. Great intro. Tevin knows basically my entire CV, so was well able to introduce me there. But for you, those of you who don't know me, my name is Emily O'Dowd. As Tevin said, I'm a senior lecturer in RCSI in surgical education and human factors and patient safety, and I lead out on the postgrad diploma and MSc in human factors and patient safety. I'm very lucky to work with some of our speakers today on that program, who also teach on the program, and then also the others are alumni of the program as well. So really great to see that kind of community getting built up in human factors and patient safety and in healthcare in Ireland. So I suppose, my own background, similar enough to Marie. I started out in psychology. I think there seems to be a certain number of kind of pipelines for human factors. Kind of you've your engineering side and you've your psychology side to start off, and then people who come at it from, I suppose, real life experience in whatever industry they may be working in. So my own background is in psychology. I did my undergraduate in Cork, and then wasn't quite sure. I knew I wanted to do something in research. I knew I wanted to do a PhD eventually. So I went off to Edinburgh to build up my research skills, still in psychology. And then I started thinking about coming back to Ireland and looking for a job. So I spotted one in Galway. There was a research assistant job working with Dr. Paul O'Connor over in the University of Galway and Sinead Lydon. So again, two human factors psychologists and behavioural psychologists who work in this area. And a typical Irish person in my early 20s rang my mother to see what she thought of the job. What did she think? It was a little bit different to what I was used to. It was based in healthcare. I wasn't really used to that, but she's a nurse, so she was like, oh, definitely do it. That's a great idea. So that's how I got into this whole world of applying, I suppose, my original psychological knowledge and experience in research in that field into human factors and I suppose medical education as well. I think my dawning of realization that I was actually working in human factors took a little while. It was probably when I actually went up to the Irish Human Factors and Ergonomics Society annual conference when I was a PhD student and presented on a project we were working on resilience and well-being. So it's interesting that Marie mentioned that earlier. And I was like, why am I going to an Ergonomics Society conference? I was very confused. And until I started listening to all of the talks that were going on and understanding what was happening in that space in Ireland, I didn't really realise. I think our PhD supervisor let us kind of figure that out for ourselves, that we were actually working in this field and what it was. So yeah, then started working in RCSI after my PhD. My PhD was focused on complaints made about general practice. So I suppose taking a systems level approach to complaints. So obviously complaints in healthcare are typically dealt with on a one-to-one basis. They're dealt with individually. Learning isn't really typically shared further than maybe unit level or practice level if it's in GP or in community. So we wanted to apply some tools that had been used in the UK to hospital level complaints to general practice. So I redesigned a tool and wanting to look at, I suppose, what maybe we can learn. It's kind of retrospectively from complaints, but then proactively put in place in order to prevent things from happening again and spread that learning from complaints. So if something is happening in one practice in rural Ireland, it might be happening in another, and you might be able to prevent patient harm in that way. So that's where I came from. And then obviously coming up to the College of Surgeons, I started to really learn what was going on in human factors in Ireland in general and across the world. So we obviously, as Tevin has mentioned, we have our National Human Factors and Patient Safety training program. So we have the surgical trainees and the emergency medicine trainees nationally have to attend mandatory non-technical skills training with us here in the RCSI. And so we teach them communication skills with each other, with the patients. As Mo said, these are, particularly important for improving patient safety. And we teach those through simulation. So really kind of interesting, I suppose, way to access this group of people who are constantly, at that front line and front end, sharp end of working in healthcare and trying to make patient care safer. And then the other side of my role is running the postgrad diploma and the Masters in Human Factors and Patient Safety. And yeah, again, a really great way to, I suppose, interact directly with people who are working in these roles and who can start to apply the theory and the knowledge on human factors to their real lives and to kind of make a difference in their units, in their hospitals. And yeah, because we're very lucky, it's an online course. We have people from all over the world. I can see people from Paul joined from New Zealand there. So, we've a nice mix of people and learning about different systems, different countries, cultures. Yeah, it's just really fascinating. I'm going to stop there because I think I've hit 5 minutes. But yeah, I just want to say thanks so much and looking forward to any questions in the conversation afterwards.
Thank you so much, Emily. That was very comprehensive. As I said, we work with Emily quite closely, but the amount of work that you and the team do in terms of mandatory training, the program, our national conference, we also have a podcast as well. But it shows testament. Like, I love the way in terms of your career path has gone from psychology and then going into human factors, but like kind of understanding once you've gone to kind of these societies and these conferences and kind of working in Galway, etc., that you've kind of found yourself, developing kind of the skills and knowledge and the interest. So, like everyone has a different career path, but that shows you that, you don't need to be gung ho and say, oh, I've dreamt of human factors all my life. You can kind of get into it in terms of the people that you're surrounded by. So that's fantastic. I'll now pass on in terms to the next person, who is Ivan McCann. So Ivan McCann is a Quality and Patient Safety Manager in the HSC, and he's also a critical care paramedic. I've had the pleasure of meeting Ivan in our Human Factors and Patient Safety National Conference, and Ivan's has done our program as well in terms of our Human Factors and Patient Safety postgraduate program. So Ivan, I'd ask you to give maybe just a perspective in terms of how you got into human factors, and then in terms of the impact and stuff that you're doing in this field when, in your specialty.
Yeah, absolutely. Thanks so much, Devin, and thanks to everyone who's joined us this evening. So, as mentioned, my name is Ivan McCann. I guess I started out in human factors kind of accidentally, which I think is maybe a reoccurring theme as we kind of go through the discussion. Probably started out in it without knowing what human factors was. My clinical background, anyway, I've been a paramedic for the better part of 15 years, mostly in Ontario, Canada, but been very fortunate to be able to do a bit of work around the world as well. So, in that context, early on in my career, I was very kind of surprised, maybe isn't the right word, but as a brand new paramedic, you're given this toolbox of drugs and interventions and told to go out into the world and save lives. And it really kind of got me thinking early on in my career about the responsibility that was given to a 23-year-old kid, I will say, to go out into one of the busiest services in Canada and deliver emergency care in, these unpredictable, chaotic environments, often just with yourself and someone else, but then also with ad hoc teams, because we'd interact with other services and eventually the ED. So that kind of sparked my interest in it. And so subsequently, I then got a position with our regional regulatory body. So when I say I fell into human factors kind of accidentally, that was it. I was doing a lot of quality assurance, clinical audit, a bit later on, a bit kind of CPG design. But I think it's funny at the time, I was doing all these bits and pieces that, one might say belong in the realm of human factors and ergonomics, and just didn't know it at the time. What little I did know back then was, maybe yourselves on the call would agree, we kind of think of crew resource management and communication and clinical audit, incident reviews, things like that, these facets. So I did kind of have that kind of perspective on it. So doing human factors for several years without knowing it. So fast forward to 2020, I relocated back to Ireland, had a unique opportunity to do a bit of work overseas, and was able to do that, and eventually found myself in a position with the HSE, working in community healthcare. So I work initially as a quality and patient safety advisor, and recently got a position as the QPS manager. And I suppose I found, in the context of my previous roles as a paramedic and now working in patient safety and community healthcare, there were definitely a lot of parallels that were coming up. I think Emily kind of touched on a couple there, but these teams, multidisciplinary teams operating outside the four walls of an acute hospital, and what patient safety and what human factors look like for these teams. So that was very much kind of the day-to-day bits and pieces, and I'll say, just from kind of the community perspective, the patient safety movement is there, and human factors, there is an awareness of it, but I think there's a lot of opportunity to grow further in that field. So that's kind of what I do now. As Emily mentioned too, I'm a recent graduate of the Human Factors and Patient Safety program as well. So in that context, the program, as well as my previous experience in human factors, have kind of, piqued my interest in, system design, and very much around kind of patient safety incident review, just culture, as well, especially in the context of out of hospital care, because these kind of incidents do happen in that context. So I've been very fortunate, having finished the program and learning so much from the program too, taking those lessons, those theories, and being able to bring it into my day-to-day practice, and doing close work with clinicians to look at patient safety incidents, good catches, and trying to improve the system on that, in that lens. So yeah, that's kind of where I started from, where I went, and where I am now. So yeah, thank you very much.
Thank you so much, Ivan. It's great to kind of see your perspective on that in terms of your systematic approach to patient safety and human factors, and even your career path as well, in terms of the roles you've had coming back to Ireland, etc. And it kind of aligns in terms of Emily's piece as well, in terms of, what you start with in terms of your career, etc. You can find your way into kind of roles within human factors and quality, etc. So no, thank you so much for giving that perspective. We'll now pass on to Dr. Liam Chadwick. So Dr. Liam Chadwick is a chartered ergonomics and human factor specialist, and also is the founder of and CTO and chief engineer of One Unit. I've also kind of spoken to Liam quite a lot and kind of engaged, but yeah, the same as kind of the other speakers, Liam, it'd be good to kind of get your perspective in terms of how you've got into human factors and what you're doing now currently.
Great, thanks, Devin. Thanks everyone for being here. My background is quite different, I suppose, to everyone else who's spoken before me. My undergraduate degree was in mechatronic systems, so mechanical and electronic systems, so fairly hardcore robotics and manufacturing production systems. And I noticed when I came to the end of my undergraduate degree that there was very little education or consideration of safety education within the realm of engineering that I was working in, I suppose, and I thought that was a huge opportunity perhaps to move into and have that expertise as well. So after my undergrad, I went to the UK to University of Warwick and did a research master's there on safety critical systems. So looking at how do we manage risk in complex environments, and from micro to macro scale. So looking across national, how do we sort of nudge the population to do things that are safer for themselves, perhaps, and then also carry those down to the micro levels within systems. And then after my research master's, I decided to continue my research and education and look for PhD opportunities, and came back to Galway here, joining the Industrial Engineering Department, and working with Mr. Enda Fallon, who had several years of human factors and ergonomics expertise from the nuclear industry in the UK. And we got chatting and talking, and given that I'd done a number of modules and as part of my research masters on reliability, maintenance, risk management, risk assessment, systems design, systems analysis, we started thinking about how those tools could be transferred, which was sort of popular at the time. It was, sort of 2007. How we could adapt those tools from traditional safety critical industries and apply them into healthcare, which was sort of de rigueur at the time. So I finished my PhD in 2010, went to Australia as a research fellow at the University of Monash, working for the Centre for Research Excellence in Patient Safety, working on a sort of interdisciplinary project there, looking at decision-making within complex clinical environments, so trauma care, ICU, and then around total hip and knee replacements. And the focus really was on blood use and decision-making around blood use in those environments. That was very interesting to do that for a while. But while I was there, I met an American hospitalist who was on sabbatical, who was helping to launch a clinical microsystem model that he had developed in America, called the Accountable Care Unit at the hospital there. And when I saw the work that he was doing and trying to bring, interdisciplinary teams together with some structure and purpose, daily for every patient in a very efficient manner, sort of 3 to 5 minutes per patient meeting, I started to see a lot of the things that were spoken about or written about in the literature sort of actualized. And I thought that is very powerful. The world needs more of that. So I left my job in Australia and started a non-profit with him in the US. And that was basically us being invited to go to hospitals to help them in the US predominantly to implement the model. That went well enough that we spun out a for-profit consultancy, which we have been running for about 11 years now, providing services to hospitals in the US, Canada, and Australia. Little bits in New Zealand, anyone else who sort of is interested. And that sort of really gave me an opportunity to travel around and see lots of different clinical environments, different health systems, remotely. So I used to travel an awful lot before COVID, not so much since then. I've been doing that for the last 10, 11 years. And really, like as Mohammed said, we have we can look up anything now. We can look it up and have it at our fingertips, but that still doesn't mean that we're actually going to give evidence-based practice or best practice to the patients in the hospital. And I think if, as human factors engineers or ergonomists or human factors psychologists, human factors practitioners, when we come together and we understand the working environments and what the people need, and the people being the patients, the customers, and the staff also as customers, and how we can leverage the existing knowledge that they have, but just help people to bring it together more efficiently, we can significantly improve the quality of care that we're delivering. And I'm talking about the first studies that we worked on. They were seeing reductions in mortality of 50% or 52%, and we've been able to reproduce that, reduce length of stay, reduce adverse events, infections, improve patient and staff satisfaction. The real quadruple aim. And I think as human factors practitioners, we have the ability, or the onus is almost on us, to be that third party person who comes in and takes an objective look at what is being done, and where it needs to get to, and to develop or design and help the people get from where they are to where they want to be, as efficiently and safely as possible. And yeah, I've been involved with the Masters with the RCSI for the last couple of years, doing a little bit of teaching and supervising students. I've also supervised students here on the Masters program in Galway. I still do some undergraduate teaching in the university here for engineers as well. So trying to bring a lot of things together and bring them to the front line of care. So I'll stop there. Thanks, Tevin.
Thank you so much, Liam. I think that was fantastic to hear in terms of how you got in. Again, in terms of your career path into human factors, it was kind of its own kind of specific kind of entry point. But then obviously the work that you do on our program as well, and your perspective in terms of evidence-based kind of practice, etc. So I think that's fantastic. What I'll ask though, in terms of all the speakers, maybe to turn on your cameras, because we're going to go into our live panel, which is going to be very engaging, whereby we ask anybody in terms of attendees to submit any questions through via the chat or put your hand up. As again, we want this as engaging as possible. So again, I'll now pass on to my colleague Christina Tiserman, who will now chair the live panel.
Thank you so much to all of our panelists for sharing your inspiring stories. I really enjoyed listening to everyone. So as Tevin said, my name is Christina, and I will be guiding our Q&A session today. So this is a great chance for you to ask any questions to our panelists, or even if you have any comments that you just want to add in. We've already received some great pre-submitted questions already, so we'll be keeping an eye on the live chat, so feel free to drop any questions in there as we go. Or you can also press the raise hand icon if you prefer to ask your question by speaking instead. So you have two ways of engaging, whichever way you're most comfortable with. We will kick off with a pre-submitted question. So the first question I have here is from Mohammed from Iraq, and Mohammed is a general surgeon. Their question is, how can surgeons alone implement patient safety measures in a system that's not optimal and other healthcare members and administrators aren't interested and involved? So I think I will direct this question first to Dr. Mohammed Salem, as I know you have practiced not only in the UK, but also in Egypt and Jordan. So I think it would be great to get your international perspective first.
Well, thank you very much. So I have been to Iraq, and I think it's a great country. But as I say, what I would tell you is you can't get a single speciality. You have to get involvement from all the stakeholders. When you get involvement from all the stakeholders, everybody, this is when things are going to start changing. And there's a great saying that, you know, if you want to go fast, go by yourself. If you want to go far, use a team. And I think one of the simple things is how the WHO checklist has changed lots of things and improved patient safety just by implementing one simple checklist. I would say that anaesthetists play an important role, anesthetic nurses play an important role, surgeons play an important role, obviously scrub nurses play an important role, recovery nurses play an important role, and that's just in the theatre environment, as well as obviously adding in the porters that transport patients or transport blood products. So if you get all these people in the same room and say, how can we work together to improve the situation, improve patient outcomes, you will come up with simple stuff. And these simple stuffs are such as the team briefing that we have in the morning, where everybody comes up with what is needed from their perspective to deliver the best patient care. And once you've implemented this, the team dynamic suddenly changes. You're, as a surgeon, not suddenly asking for something mid-procedure that maybe if it has been mentioned earlier on, they would have gotten it prepared. The anaesthetist, for example, is aware that this patient is anemic, and you're aware that this patient is anemic, and obviously the blood is prepared and ready in the bank. And it's these small, simple steps. Once you add them up together, they will actually make everything much, much bigger, and it will just make a smoother patient's journey and a lot safer. So I think just start looking at the simple, basic stuff and take it bigger and bigger and bigger afterwards. Communicate earlier on, share the decision load together, and use communication tools, because once we use communication tools, we suddenly all speak the same language. I hope this answers your question.
Thank you, Mohammed. I'm not sure if that person is now online to get back to us, but they will receive the recording. Our next question here is from Misha. They're writing in the chat. Thank you for the insights. One of the things resident doctors in the UK find challenging is getting into pathways to get chartered or have human factors whilst on training. Do you have any advice or suggested pathways for full-time workers? So I don't know, would anyone like to volunteer to take that question?
Would you mind if I suggest that Liam or Marie would be the best people, or maybe Emily, obviously? I mean, I'm not chartered yet.
Yep, of course. That's great advice, Mohammed. So yeah, maybe Liam or Marie.
Yeah, I think Marie was going to jump in there, but
yes,
I'll have to go after.
Yeah. So just to say, the Irish Human Factors and Ergonomics Society, we don't actually. We're a very small society, and we're all volunteers, so we don't provide a chartered status, but we provide a route for people to achieve chartered status with the UK Society or with the European Society. So you might see the term EU or Ergo, which is a European chartership for human factors ergonomists. I understand your point in terms of getting chartered, but I suppose chartership is it's part of our profession as a science and as a discipline. And I think maybe there's a bit of misunderstanding about the fact that human factors ergonomics is a science. So to be chartered, you have to have a really firm understanding in the science of human factors. And both the Irish Society and the UK Society, we do a competency framework for people to become members. So just to say, anybody is welcome to become an associate member with the Irish Society. We're more than happy to have anybody as an associate member if you have an interest or a passion or a desire to learn more about human factors. Chartership is a different level. It is, having a competency, it's understanding. We require people to have like a PhD or a master's and peer-reviewed publications and experience in the field to become chartered. So it is a different level because it is the height of our kind of scientific discipline. It is, Liam, I don't know if you'd add to that or
Yeah. You ready? Yeah. I think in the UK in particular, there is sort of a recent progress to pushing for a human factors specialist within each of the trusts. And they are providing training through the University of Loughborough that's been specially designed. Mike Frey and the guys there are providing that to help upskill healthcare practitioners in human factors who are then based within the trusts and are the go-to person for human factors sort of projects. And I think the first thing, Misha, you could do maybe is try and find out who that person is within whatever trust that you're working in, and try like just reaching out. There is a network that they have, they've sort of built a little online network for themselves, I think, through the Chartered Institute as well in the UK. So if you can find one, you'll basically get access to all the others. But seeing how you could get involved with some of the projects that they're working on, which might be within the realm of your scope of practice or expertise, or might be beyond it. And, in all fairness, go and get stuck into things that are outside of your comfort zone as well. Mo?
Yes, I was just going to add something, and I'm not sure, maybe Emily is the best to add or drop into this, but try and join the postgraduate diploma or the MSc in human factors. It is, look, I mean, I'm not, bigging myself. I've got 9 degrees, most of them are in medicine. I've got a master's in business administration. The one degree that I think has made me a different person in a very critical environment is my understanding, my humble understanding next to the people who are around me here at the moment of human factors. And I think it is actually life-changing as a medic.
Thanks, Will. That's a very nice thing for you to say. And I think it's much more powerful coming from you than from me. But I think I'd echo what Liam said as well, just to maybe just get stuck in anywhere that you can. You can see from all of our journeys that it's not a straight road, it's a winding road. And I see the trainees in Ireland and how busy they are and how much there is going on. So do try and just, not overwhelm yourself. It's a long career, but start to see where you can get involved locally and try and even start reading about it in your spare time that all these doctors have.
Yeah, Liam, do you want to add something there?
Yeah, no, there could be some micro-credentialed courses available in the future, or maybe around that you could look to sort of dip a toe rather than committing to a full-on diploma or master's. But that was it. Ivan?
Yeah, actually, Liam, you took the words out of my mouth there. One of the very first kind of human factors-esque micro courses I did was a patient safety one from the IHI. It was an online kind of short course like that. So definitely, for anyone who's looking to dip the toe, I would would definitely suggest maybe kind of exploring that. And then also, like, from a very practical standpoint, and I can attest to this working in quality and patient safety in the HSE, like, if you have someone in your hospital, your trust, wherever you're working, that does patient safety or, you know, quality improvement or something like that, reach out, because I suspect they're similar to myself. We're always looking for people to work with, especially clinical folks, frontline folks, to you know, work on small projects and things like that. So, you know, get the opportunities where you can find them, I suppose.
Thank you, Ivan. I hope that answered your question, Misha. We'll move on to the next question here in the chat. That's from Lisa McVeigh. Lisa is asking, is there any shadowing opportunities to gain a bit more insight into what the day-to-day role is like working in patient safety? Currently, HCP and interested at pursuing non-clinical roles. So I think who would be best for that is those of you that are currently in those non-clinical roles. So I think that's you, Ivan, Liam, and Marie.
Yeah.
Probably.
Yeah, so look, Lisa, as Ivan just said, I mean, I'm the only embedded human factors researcher in the hospital that I work in. None of my work would happen without clinicians, you know, so I have to work, like, and I absolutely love working in partnership with them and trying to be as multidisciplinary and transdisciplinary as possible. So absolutely, I'd say the person in your hospital, if you just approach them, I would say they would be absolutely delighted. There's always projects we're working on that we need help with, and so yeah, please just reach out to, you know, human factors, as Ivan said, quality improvement, patient safety, health systems. You know, there's lots of different names, so please just reach out.
Yeah, I might just chime in there too, just on that tail, if that's okay, Christina.
Yeah,
just
go
to
ahead.
echo again what Marie said, like, just, you know, at least in the community setting too, we've had great opportunities, once you kind of get boots on the ground, so to speak, to engage with frontline staff who, you know, have amazing perspective and, you know, really brilliant ideas. And from the human factors perspective, you know, that collaborative piece, that multidisciplinary collaborative piece, sometimes it just takes a quick phone call, or, you know, sit down and have a quick chat. If you're on a ward or you're on a unit, you know, you ask the question, oh, what about this, or what do you think about that? You'd be amazed at who will put their hand up and want to engage. So absolutely, like, you know, at least from the quality and patient safety standpoint in the HSE, we're always keen to engage with, you know, clinical staff, non-clinical staff, to look at system improvements.
Thank you, Ivan, and Marie, and I hope, Lisa, that answered your question. We do have time for maybe one or two more questions, so please drop it in the chat. In the meantime, I will take one more pre-submitted question. And this question is coming from Boyd Shepo. I hope I'm pronouncing your name correctly. And they are a nurse from the UK, and they're asking, when is the application for the next intake opening at RCSI? Emily, would you like to take that question?
I nearly feel like you should take that one, Christine, as you've been working on it.
Yes, that's true. Yeah, so we are opening our applications tomorrow around lunchtime. So do check out our website, and around lunchtime you'll be able to find more information there. You can also email us at postgradsa@rcsi.ie if you have any questions. Yep.
Yeah, and I'm
Anything
also
else?
happy to answer any questions. Like, if people want to get in touch with me directly, find out a little bit more, or get in touch with Christina, and she'll get in touch with me and send on any questions my way as well.
Perfect. Thank you, Emily. Oh, yeah, Lisa got back. So thank you. That's brilliant. We'll try to reach out and find out the patient safety manager locally. That's great that you found the information helpful. Brilliant. I think if there are no more questions, we do have here one more question from Taya. They are a GP from Saudi Arabia. I think they're asking more about career choices. So in particular in Saudi Arabia. So the question is, what are the career choices for patient safety specialists in their region? I don't know if that might be kind of a difficult question. Would anyone have any insight into patient safety roles in the Middle East? Yes, Mohammed. I was hoping you'd put your hand up.
Thanks. I mean, obviously, I'm not an expert on what happens in the Middle East. However, what I would say is, as things stand at the moment, I think the Middle East healthcare system is very well developed from a technology perspective. I think they currently have, and especially in Saudi, more latest technology than we would have in Oxford. But I think because quality is such a big issue, I think now they will be or have been starting to look at having human factors and quality specialists in hospitals across Saudi. And I think for the medic who's asking this question, now is the best time to try and get into human factors from around the world, because as organizations have spent millions and millions and millions, now they're trying to look at what is going to elevate the quality of healthcare for the minimum expenditure. And as everybody feels that squeeze, I think there is a massive potential for that improvement. And obviously, I think I'm not sure if Liam would like to come in on that because of his prospect on looking at hospitals around other parts of the world. But I would say at least 2 or 3 people who were doing the course, who were sort of Western qualified medics, currently working as expats in Emirates and in Saudi. So I think it's blue skies, which is a very positive thing. However, now is the best time to get in. So there's not much competition, but there's lots of room for improvement.
Yeah, Maria, I know Maria has her hand up, so.
Yeah, Marie, go ahead.
Yeah, no, I just wanted to say that the International Society for Equality in Healthcare have revised their standards. So they accredit the accreditors, all right, in healthcare. And they have introduced 3 new chapters. And I think these are critical in terms of human factors. So one of the chapters is on, one of the standards, sorry, is on healthcare professionals' well-being. So this is a new development given the global shortage of healthcare workers, burnout, all of the things that are affecting fatigue, that are affecting healthcare workers. So human factors has a huge role to play in human well-being at work. So I think that's a really important development. And then the other standard that the International Society for Equality in Healthcare are promoting is digital and AI, so digital telemedicine, AI. And again, human-centered AI has been advocated as the only way that we can approach bringing such technologies into healthcare. So I think human factors has a huge role to play there. So, just make sure you understand the full range of the discipline of human factors, and there are always opportunities to get involved because the way that, as Mohammed spoke to, our organizations are getting more and more complex. We don't know each other as much as we used to. They're not as small. A patient 20 years ago saw on average 2.5 clinicians. Now they see 25 clinicians. So there is just massive complexity in technology and staffing and everything. So understand, I would suggest, know what your interest is, what your area of interest is, and then understand the human factors of that area, and then get your qualification to support that, because there are huge opportunities. That's it, Liam. Sorry, I didn't mean to interrupt you.
No, you didn't. No, I see the same. Canada, America, Australia. There's there's a growing number of health systems and hospital systems that are starting to recognize the potential benefits of human factors expertise. And they might not necessarily employ, they might not advertise a job as human factors practitioner or, ergonomist or whatever it is. But it might be a role in the quality office, or it might be a role, like maybe if they've got lean systems or a lean thinking group, there might be a role in those departments that has more of a human factors perspective or component in it. So keep an eye out for those. And certainly in the UK, now that they're moving to having an embedded HF practitioner in each trust is a great sign. If we did the same in Ireland and we had, a Marie in every decent sized hospital in the country, wouldn't all of the care be better, and wouldn't all the staff be happier?
Thank you, Liam. Ivan, please go ahead.
Yeah, just real quick, just kind of on Liam and Marie's notes too, just kind of back to the original question too. And I mean, the hospital focus obviously, but I'll advocate for out of hospital care as well, because, as kind of systems are transitioning towards more community-based healthcare, I think there's massive opportunity for human factors specialists, patient safety specialists, and things like that. Anecdotally speaking, and in my own kind of practice as well, to kind of get into those fields, because while those systems have been there for a long time, we're starting to see further integration between in-hospital and out-of-hospital care, especially with the pressures on healthcare systems internationally speaking. So, just something to consider, in your own kind of journeys as well, to as kind of Liam mentioned, look outside the box and kind of take into account the different maybe terminology that's used and maybe different environments that human factors is used in.
Yeah, that's brilliant. Thank you so much, Ivan. We do have one comment in the chat there. So just to answer their question, yes, we will have this event recorded, and we'll be sending you a copy in the following days. In case anyone has joined later on, you'll be able to watch it back at a later time. So apologies. As we wrap up, I would like to sincerely thank our panelists for sharing their journeys and their expertise with us. That was very, very inspiring. And for our audience who asked such thoughtful questions, if you'd like to continue exploring in the area of human factors, ORCSI does offer dedicated programs in human factors and patient safety. So we encourage you to connect with us for more information there. As I said, you can contact us at postgrad@orcsi.ie. Yep, I hope that tonight has inspired you, and you got to see the many ways that human factors can shape safer, more effective healthcare systems. Thank you so much for joining us, and we look forward to seeing the impact that you'll make in this evolving and important field.
So,
thanks, everyone. Thanks,
Thank
Christina.
you.
Thanks, Evan. Thanks, Rebecca.
Thank you.
Thank you.
Thank you.